So good morning, everyone. Again, thank you all for virtually attending our special tribal consultation around differential adjusted payments. The purpose of this tribal consultation is to really host a conversation related to our preliminary public notice, which was posted to the Access website on March 6th. This notification went out to a variety of agency constant contact lists. It is a 32-page document, so I might be speeding through some things, but it's still posted online. And of course, any additional questions and comments can be submitted to us via email. So the overview and purpose of the differential adjusted payments. We published the preliminary decisions for our differential adjusted payments to be implemented in the contracting year October 1st, 2020 through September 30th, 2021. And so you will also see, you'll see CYE, and that's the contracting year that also corresponds with the federal fiscal year. This also addresses future DAP reimbursement strategies that we may be considering for implementation in CYE 2022 and thereafter. And I know that that seems like a far timeline, but of course we want this to be a dynamic process so that we can start dialoguing. So there are a number of different provider types that may be eligible for the differential adjusted payments. The purpose of the DAP rates are to assure that payments are consistent with efficiency, economy, and quality of care and are sufficient to enlist enough providers so that care and services are available at least to the extent that such care and services are available to the general population in the geographic area. Access will implement these rates for the following providers. There's hospitals, critical access hospitals, other hospitals, and inpatient facilities, and we'll go over in a bit more detail the different provider types. I do want to note that the DAP rates will expire after September 30th, 2020. The current DAP rates that are in place will expire. This particular DAP that we're talking about is the 1 year for the contract year ending in 2021. These rates represent a positive adjustment to the access fee-for-service rates, and the purpose is to distinguish providers which have committed to supporting designated actions to improve patients' care experience, improve member health, and reduce cost of care growth. These rates are positive on the fee-for-service rates, so they would be applied under fee-for-service and or under the managed care organization. Under a given DAP initiative, the DAP increase may be applicable to all claims paid. I also want to note that they are also subject to approval. Of course, we know in terms of federal and state budgets, we do have to maintain alignment with our federal and state partners. I also just want to note that it is all subject to budget availability, and since the legislature passed only a skinny budget or a baseline budget at this time, they do have to come back into session to finish the budget, and there is uncertainty at this time. So it's just very preliminary in terms of the differential adjusted payments, which are subject to federal and legislative approval. Okay, we can move on. And I am watching the time, so we'll move quickly through the next couple of slides. Next slide. Okay, so hospitals subject to APR-DRG reimbursement. This is provider type 02 are eligible for DAP increases under the following criteria. Health information exchange participation, and we'll do a deeper dive into the HIE participation in a couple slides down. Then there's the health information exchange performance. And so delineating between A and B, health information exchange is for those hospitals that have not previously participated in the HIE, and then B is for those providers or those hospitals that have previous experience with the HIE, continuing to see the evolution of the engagement with the HIE. C is sepsis care performance, and one of the things that I wanted to point out related to the sepsis care performance measure is that as of April 30th, 2020, Access will download data from the Medicare Hospital Compare website for the early management bundle severe sepsis septic shock performance measure. Then there's the long-acting reversible contraception, and for that, we would qualify for a DAP on a subset of J codes, and those are outlined again in the DAP preliminary notice. Then there's on-site peer support for substance use disorders. And so high level, that would mean there's criteria for providing peer support in inpatient or emergency department settings as a substance use disorder treatment. And so there are provisions around a memorandum of understanding or a memorandum of agreement between a hospital and a peer support organization. And then F, there's an inpatient or emergency department medication-assisted treatment, and that one entails criteria for initiating buprenorphine medication. I do want to note that both E and F have asterisks because the percentage rate is still to be determined. All the other measures do have an associated rate that is published in the notice. Okay, next one. Moving on to critical access hospitals. And I do want to apologize. So Amanda, I owe you another. I was reviewing last night, and there are two that crept in on the critical access hospital slides that I should have removed. So the actual measures under this include the health information exchange performance, the long-acting reversible contraception, the on-site peer support services for substance use disorders, and inpatient or emergency department medication-assisted treatment. And you'll see very similar or the same criteria under these requirements for our critical access hospitals. Okay, moving on to the next slide. So talking about other hospitals and inpatient facilities. So I'll list out the provider types that fall under this provider type. It includes provider type 71, secure residential treatment centers, provider type B1, non-secure residential treatment centers, B3, subacute facilities, provider type B5, subacute facilities, provider type B6, rehabilitation hospitals, provider type C4, long-term acute hospitals, provider type C4, are eligible for DAP increases under the following criteria. And again, the link will be incorporated. Again, all of this is detailed out online. And so you'll see very similar criteria: the health information exchange participation, the health information performance. I do want to note C, the inpatient psychiatric facility quality reporting program. In terms of those criteria, that is one of the things that is different from the other hospitals. And we would look at qualitynet.org to identify Medicare's annual payment update recipients. APU recipients are those facilities that satisfactorily meet the requirements of the IPFQR program, which includes multiple clinical quality measures. Facilities identified as APU recipients will qualify for that increase. And then we do have a pressure ulcers performance measure, long-term care hospitals, as well as inpatient rehabilitation. And so we would look at the Medicare Inpatient Rehabilitation Facility Compare website, as well as also look at the Medicare Long-Term Hospital Compare website. And those are also identified in the preliminary notice. And then you'll notice F&G, the peer support, and the inpatient ED MAT requirements are similar to the other hospitals. Moving on to number 4. Indian Health Services and tribally owned and or operated 638 facilities. So this one is new, and I wanted to provide a little bit more context related to our IHF and 638 facilities. We have previously never applied a DAP directly to IHS or 638. So we are venturing a little into the unknown related to this one. We do have to, of course, get this vetted by our federal partners because it's something that we don't have previous experience with. It's hard for us to predict the likelihood of that occurring. But we are willing if, again, just really seeking public comment. Is there support? Is this something that Arizona should pursue? Really, our thought process is around the health information exchange. We know that we do have some IHS and 638 facilities that have established interoperability with the HIE. That has historically been tied to our American Indian Medical Home as one of the higher tiers. However, we're proposing for additional DAP be applied independent, even if the facility has not achieved an American Indian Medical Home designation. And then the proposed rate is the 2.5%. And then, of course, it would correspond with the updated OMB rates that we anticipate being published any day now. There are milestones associated with the HIE participation. And the first milestone identified is no later than May 1st, 2020. In terms of having a participation agreement with a qualifying HIE organization and submitting a letter of intent to Access and the HIE in which it agrees to achieve the following milestones by the specified dates. The second milestone is no later than November 1st of this year, must approve and authorize a formal scope of work. And then milestone 3 is March 1st, 2021. The facility must electronically submit actual patient identifiable information to the production environment of the HIE, including admission, discharge, and transfer information. Then milestone 4, May 1st, 2021, facility must electronically submit the following actual patient identifiable information to the production environment of a qualifying HIE organization, including laboratory and radiology information, if the provider has these services, as well as transcription, medication information, immunization data, and discharge summaries that include, at a minimum, discharge orders, discharge instructions, active medications, new prescriptions, active problem lists, treatments and procedures during the stay, active allergies, and discharge destination. The last milestone is if the facility has ambulatory or behavioral health practices. Also by May 1st, facility must submit actual patient identifiable information to the production environment, including registration, encounter summary, and SMI data elements as defined by the HIE organization. So I know that that was a lot, but that's the initial HIE participation. And then, of course, we do have Ms. Dye with Health Client, and she can talk a lot more from the HIE perspective and what their organization has in place to support facilities, hospitals that are interested in pursuing this partnership. We can move on to the next slide. And then nursing facilities include pressure ulcer performance, urinary tract infections, and national quality awards. So just a note on the urinary tract infection, we would look to the Medicare Nursing Home Compare website to look at the percentage of long-stay residents with the UTI. And look at where that facility lands on the results for that measure. And then again, you'll see the asterisk with the National Quality Award Program recognition. And we would look at nursing facilities that receive a bronze, silver, or gold rating from the American Healthcare Association and National Center for Assisted Living National Quality Awards Program. Okay, we can move on to the next slide. So integrated clinics, provider type IC, eligible for an increase of 10% for selected physical health services, looking at licensure, of course, being licensed with DHS as an outpatient treatment center for both behavioral and physical health services with behavioral health utilization at least 40%. And then we see the health information exchange. Next slide. Moving on to behavioral health outpatient clinics. These are provider type 77s, seeing, of course, very similar to what we saw under the the IHF and 638 hospitals, the health information exchange participation. We can move on to number 8, behavioral health outpatient clinics and integrated clinics. So an overlap for both provider type 77s as well as provider type ICs. Partnership with schools to provide behavioral health services. And I think, can we move on to the next slide, please? Partnerships with schools. And there are a series of codes that would qualify in conjunction with Place of Service 03. We also have Autism Centers of Excellence, clinic that is considered to be an Autism Center of Excellence is defined as a provider that has identified in the value-based provider centers of excellence attachment in its provider network development and management plan. So working in conjunction with the managed care organizations. And then I do want to call special attention to the provision of services in members in a difficult to access location. This is a continuation. We currently have a DAP in place for this one. And this is for a clinic that meets criteria for provision of services to members in a difficult to access location that cannot be accessed by ground transportation due to the nature and extent of the surrounding Grand Canyon terrain. Will qualify for a DAP of 3% on all claims. A provider has to have an MOA or an MOU with a tribal government to access tribal territory in order to provide the behavioral health. So we do have a couple of providers that do have that in place, and so continuing to see that extended. Moving on to number 9, physicians, physician assistants, and registered nurse practitioners. These are known as provider types 08, 18, 19, and 31. The electronic prescriptions, and so there's very specific numbers in terms of how we would quantify the electronic prescriptions, and then looking at 6-week postpartum visits. Moving on to dental providers, provider types D1, D2, D3, D4, 07, and 54 are also eligible for under 2 areas. Dental fillings for children performance. So looking at providers that increase the number of access children ages 5 through 15 to whom they provide dental fillings to. And then looking at the provision of dental services on weekends. So looking at the dates of service, tracking it from that perspective, whether it's a Saturday or Sunday, seeing the increased services provided on those days. And then we're nearly in the home stretch. I feel like I've been talking quite a while, but moving on to home and community-based service providers, looking at the electronic visit verification, readiness, participation. Hopefully this group is aware of the EVV requirements that are going into place as required by federal regulation. These DAPs are really to support the system in making that seamless as possible. And then looking at home and community-based settings, the compliance participation, looking at key qualifiers related to that piece. I do want to note that the provider types, there's a variety of provider types that have the potential to qualify. That would include A3, F1, ICs, 23, 39, 40, 46, 77, and 95. And then also looking from the frame of reference in terms of where the service is being rendered, place of service 12, which is the home, 13 assisted living facilities, and 99 other. And there, I would point in terms of there is more information in the public notes attachment. Okay, so that's a lot of information. We'll move on. Just a couple more points that I want to make. As mentioned, we also talk about what we're thinking about in terms of the subsequent year. So looking at CYE 2022, we do have more information embedded in our preliminary notice. and that would be the future of the HIE initiative. We've talked about where we're potentially going, and very much welcome your feedback related to that piece. We do communicate in terms of how DAPs will continue to evolve. And then just in terms of timelines, we'll still be working through this process over the month of April and anticipate a final posting in early May. And then, of course, we do have to, the final request for approval is due to CMS this summer. And we'll engage our federal partners in that in preparation for an October 1st application. So, Amanda, I hope I stayed within my time frame, went through a lot of information, fully acknowledge that, but also would point out that a lot of it can be processed by accessing the preliminary public notice. And with that, I'm done.
Marquis, there's a chat question asking if those provider types that were mentioned would be listed with the presentation.
I've already noted that I have revisions to make. I can certainly add those in.
Okay, Amanda, are there any other questions?
Yeah, this is Amanda. Sorry, I was on mute. We have another question that came in to me from Victoria. And Victoria, if you're on the phone, I'm going to unmute you right now. If you could ask your question. I believe your question was regarding, I want to say the IHF slide that we went over, so number 4.
Yes, thank you very much. Hi, Amanda. Hi, Marquet. How you doing? So we're noticing now that the IHS and Tribal 638 are being included in the DAP. It seems that it's only for the hospitals. Is that correct? And not including the Tribal 638 FQHCs? And if the answer to that is yes, is Access considering perhaps in the future including the T38 FQHCs? Pardon me, the 638 FQHCs?
That's correct, and this is exactly the type of feedback that we would welcome. So we will definitely note that as a request in terms of the FQHCs versus the hospital provider type.
Thanks very much. Thanks for everything you guys are doing.
Those are all the questions that I'm seeing from my end. If there are any more that come in, we can, I'll shout them out towards the end of the next presentation. So now I will turn it over to Christy Dye for the Health Current portion of the presentation. Okay, Christy, are you on the phone?
Did you unmute me, Amanda?
Yeah, you're good to go.
Okay, I'm live. All right, great. So Amanda and audience, thank you very much. Appreciate having a few minutes of your meeting time today to talk a little bit about Health Current and what we do. As Amanda said, my name is Christy Dye. I'm the Chief Business Development Officer for Health Current, which is Arizona's statewide health information exchange. So today I'm hoping to provide just sort of a brief high-level overview of Health Current and the types of services that we provide through the Health Information Exchange. As you've just heard, we're a fairly significant portion of Access's differential adjusted payment program for any hospitals and providers who choose to enroll to participate in this year's DAP. So hopefully today we can answer some initial questions for those of you who will be taking the next step into the DAP program. Some of you actually may have received a letter from us within the past week talking about the Health Information Exchange and the DAP program for outpatient behavioral health services. So we did do a mailing, and I saw quite a few 638 providers on that list. And then just as a bit of an apology, I'm actually still fairly new to Health Current. I myself am a former healthcare provider. I used Health Current for years, both for our DAP program as well as care coordination and care management. So I'm very familiar from the provider end of things on how it actually works. But if I don't know the answer to any technical or other question you may ask about Health Current itself at the end of our presentation, I'm happy to take those questions back to research, and then Amanda, I'll just provide you information once we have a complete answer, if that sounds fine. So let's go ahead and move to the next slide. So just a little bit about Health Current. There you go. As I said, we are the Health Information Exchange for the state of Arizona. Our purpose is really integrating information at point of care so that providers have the most information possible at the place where they are seeing the patient. So what really is a Health Information Exchange? It connects electronic medical records, so data elements from electronic medical records of a whole variety of providers. I'll go through some of those in just a moment, as well as individual clinicians, which allows them to securely share patient information for those patients that they are mutually serving. So again, our goal is really to get more complete information at the point of care for providers. And there's on this you'll see our purpose, our vision, our mission statement. We also have a strategic journey, which is fully informed health. Imagine fully informed health. Next slide, please. Okay, so a little bit about what Health Current is. We're actually a public-private partnership, and that's really an important point because we are an independent, nonprofit, 501c3 charitable organization. So we're not ourselves a government agency. We do coordinate closely with Access, Arizona Department of Health Services, and other state governmental agencies to help them forward their vision for Arizona and their goals for Arizona around excellence in healthcare. So we operate as a data trustee, meaning data suppliers, hospitals and health systems providers supply data to us that we hold in trust for them on behalf of the healthcare community. We operate, of course, Arizona's Health Information Exchange, and we have the technical infrastructure and staffing to ensure that there's secure access at the HIPAA and even higher level than HIPAA for healthcare providers who are seeking to use the Health Information Exchange. Next slide, please. In fact, I think you can just jump. Next slide. There we go. So let's talk a little bit about who actually makes up Health Current. And so these are all healthcare providers of different types. If you can see this slide, it might be a little bit small. But as you can see, we have a variety of hospitals and health systems. We have 56 hospitals and health systems participating in the Health Information Exchange. We have FQHCs, we have labs and pharmacies, 16 health plans. We work individually with a variety of emergency medical service agencies in the state, 322 community providers, which is really the large group of primary care practices and specialty practices across the state of Arizona. So just a whole variety. We have, I think somebody mentioned earlier, 87 behavioral health providers participating with us in the HIE today. Next slide, please. So this is the organizations, the providers participating in HIE that actually send clinical data. that data then is available for any other participant to query. So today we actually are a little bit higher than this. We have more than 200 data suppliers, organizations submitting different types of clinical data. So it's really a rich source of medical record information for participating providers that want to query the Health Information Exchange. Next slide, please. Just wanted to highlight a few of our 3-year growth trends. You can see some large percent change figures over there. So in this 3-year period, December 2016 to December 2019, we actually had enormous growth just in the number of active users, so organizations and individuals who are logging into the HIE in order to access patient data. We have clinical information on close to 11 million patients in the HIE today, and on any given month, well, the difference in any given month, 79,000 of those patients are being accessed through what we call our patient portal, and I'll describe that in a little bit more in a couple minutes. ADT alerts are really one of the more common services. It was one I used a lot as a healthcare provider, and Markey described that as one of the initial milestones. I think it's next spring for IHS and 638 providers to be able to achieve receiving ADT alerts through Health Current. And so those are admission, discharge, and transfer out of different levels of hospital care. And we use them a lot as a provider to know when our patients were showing up at emergency departments or when they're being discharged from a hospital, so that we can make sure that the clinicians were coordinating with that patient to get them in for medication reviews and things like that. And then finally, the bottom 2 lines on this acute inpatient discharges and participating ED visits. On the overall, Health Current is covering 97% of all inpatient discharges that occur in the state of Arizona, and 99% of ED visits, all through the Health Information Exchange. So next slide, please. Thank you. I will talk just high level about some of the services, specific services offered through the Health Information Exchange. The first, and probably one of the bigger ones, is that push-pull or query response functionality. And that can be real time, so you can query about a specific person and get gathered data back to you, or it can be automated, where the medical record is integrated with the Health Information Exchange and is automatically pulling data maybe on tomorrow's list of patient appointments. We have the HIE portal, which is really a view. It's a look into an aggregated record that's compiled across all the providers serving a specific person. So if you were to query the HIE portal or look into the HIE portal on a specific patient, you would see your procedures, but you'd also see all the other procedures from other providers, their diagnoses, their medications, visits, labs, allergies. So again, it's a really rich source of clinical data for folks. And then we have a direct, secure email for exchanging clinical information. Next slide, please. Patient panel. This really is the source for all the alerts. It's the trigger point for alerts, because we need to know from participating providers who it is that they serve, so who's their patient panel, and then who do they want to receive alerts on. So it allows a provider, a hospital, a health plan to not only receive individual alerts, but you can select an entire population for special monitoring. So we could, in fact, one that we used to use in my former life is looking at certain diagnoses or chronic conditions, and I would get patient panels just to monitor certain individuals that were at higher risk of hospitalization, say, for instance. You can also have a patient panel based on demographic factors like age. The alerts, those are the admission, discharge, transfer alerts, but it's also broader because it can be alerts based on a clinical test result. And we're going to talk just a moment about our recently launched COVID-19 lab result alerts. And then, of course, I mentioned earlier that there's a query response capability that allows you to draw in a continuity of care document. Next slide, please. And then just sort of wrapping up the basic services, the Health Information Exchange is integrated with the Controlled Substances Prescription Monitoring Database, so you are able to go straight from a health current view into CSPMP and see all the controlled substances and those prescribers of controlled substances for your patients. And then patient-centered data home is sort of a national initiative among HIEs that are working together so that an Arizona patient, for instance, that might show up in Chicago in the emergency department could query Health Current for certain types of information. So a big part of this is participation for community providers in the Health Information Exchange is free. Hospitals pay an annual fee based on their number of discharges. So all the hospitals in the state that participate are really those organizations, and the health plans are really the entities that support all other Arizona healthcare providers in participating in this. Next slide, please. Okay, so this is just an example, we call it a use case, of how Health Current alerts are being used by providers all around the state in order to receive direct lab test results for their patients who have been tested for COVID-19. So this alert just was released on Wednesday. You can also find it on our website, and it was also circulated rather broadly in the Arizona healthcare community. This is really our phase one of alerts, so that it's a real-time alert. It comes directly to your email, and it shows all test results. So whether the test was positive or negative, you're going to know that. There are second phase iterations of this being some refinements being developed right now that will allow for what we call batch alerts, which is, think of that as a report. So a report that you can request every day or every week, however frequently you want that gives you all your patients that had a test result and what the outcome of that result was. One of the things that's just in particular with COVID that's a little bit different than what's happening with reporting that's going on through Arizona State Lab. So those labs and laboratory providers that are testing for COVID, they provide their result back to the ordering physician or the ordering primary care provider that requested the test. In Health Current, if you're giving us a patient panel and that patient is on your panel, for whatever service you're providing them, you might not be the primary care provider, you can still get the test result. So I think I'm almost at the end of my, yes, just a couple more minutes so I can talk real quickly about how to become an HIE participant. This is high level, next slide please, but we are trying to expedite the process both for DAP, differential adjusted payment, because there's a time crunch now to get providers started on that journey with the Health Information Exchange, but also because of COVID-19, where we're trying to ramp up organizations that are coming to us saying, I want a new panel, I want to get those alerts so that we can get people connected as quickly as possible. So the first step, of course, same slide. The first step, of course, for HIE participation is we have a participation agreement, which is the agreement between the HIE and the provider that wants to get connected. So that's really what kicks off everything. So we just request that providers contact our recruitment department. I'll share with you that phone number and email address in a moment. We'll schedule a phone call for you, send out a participation agreement, work with you on what services you want, define that custom scope of work that they talked about for DAP, if you're going to be in the DAP program, to get you set up with ADTs and to become a data supplier to the HIE. The other piece that's necessary, so this is our standard process. The other piece that's really necessary for DAP participation is that letter of intent that Marky talked about earlier. You send one to Access to their email, and you send one to Health Current to the email that's listed in the public notice. We're asking as much as possible if providers can get us those letters and the participation agreement signed at your end back to us by April 28th, so we can make sure we hit that May 1st deadline, and you're good to go for the differential adjusted payment program. Next slide, please. And these are just our recruitment team contact information. Jamie Pina or Kim Snyder. You're also welcome just to call us. You can check us out on the website if you want to know more at www.healthcurrent.org. That will be it for me today.
All right. Thank you, Christy.
Sure.
Are there any questions from anyone on the phone right now? I'm not seeing anything come up in the chat box, but just want to make sure we're answering any questions or clarifying anything needed. Okay, so that will conclude our meeting today. Just wanted to, again, thank everybody for joining. The slides that were presented today are posted on the Access Tribal Consultation website. And as Marquet mentioned earlier, we'll go ahead and upload the edited slides that she'll be sending over, as well as any presenters' notes that we can to clarify and provide more detail to some of those questions that were asked via chat today. But as always, if you have any questions, we do have the points of contact listed in the slides. But if you have any other general questions, feel free to reach out to myself or Marquet as well. I will be exiting the meeting now. Thank you.
Thank you.